super excited that the 3 students who you're going to hear from were winners of this year's Building Trust Essay Contest. And the students had to write about their firsthand experiences with open, honest, and difficult conversations with patients and with family members who had experiences that differed from their own. And these students are named the Wolfson Scholars. And this is in honor of Daniel Wolfson, who many of you know served as the ABIM Foundation Executive Vice President for over 20 years. And Daniel, are you in the room? In the back over there. Thank you, Daniel, for all your years of service, and what a tribute to have these students named as the scholars after you.
So one morning last fall, I was sitting in my sister's kitchen. My 5-year-old nephew comes stumbling in. "Hi, Aunt Meg," he says. His voice is muffled. Climbs up into my lap and gives me a big hug, and he's burning up. "When's the last time he had antibiotics?" I asked my sister, knowing that he had been treated for strep throat several times over the past few months. "I think he might have strep again." At this, my brother-in-law perks up. "Are you sure?" he asks. And I tell him that I'm not, but that I recommend they take Max to the pediatrician to get tested. Several hours later, the diagnosis is confirmed. Max has strep yet again for the 6th time in as many months. This time, their pediatrician is recommending that Max go see an ear, nose, and throat specialist to talk about a possible tonsillectomy. "Absolutely not," my brother-in-law says. "They are not cutting in to my son." My sister rolls her eyes and asks me if I'll please talk some sense into him. And of course, my first instinct is to play the role of the concerned aunt, appeal to my brother-in-law's emotional side and talk about how much better Max is going to feel once these infection-prone tonsils are out. But then I think about who I'm talking to. My brother-in-law is one of the most intelligent people I have ever met, present company notwithstanding, of course. He has a PhD in physical chemistry, he's a college professor, and he is incredibly rational, thoughtful, and intentional. He is also deeply, deeply distrustful of the medical system. You see, my brother-in-law was born and raised in the Dominican Republic, and his earliest experiences with the healthcare system were marred with sadness and death. At a young age, he witnessed the death of his father, followed not long after by the death of his older brother. When he was studying in Puerto Rico, he said his final goodbyes to a dear friend who died following complications of an elective cardiac procedure. You see, his fears about his son undergoing a possible operation were not unfounded. And so I ask him, "What are your concerns? How can I help?" He looks at me and he tells me the pediatrician just spoke too fast and he felt like she was just rushing to operate. He asks me, why is a tonsillectomy preferred over multiple courses of antibiotics? I speak to him about antibiotic resistance and the gut microbiome. He asks me, well, then why didn't they suggest a tonsillectomy earlier if the antibiotics are so bad? And I pull up the American Academy of Pediatrics guidelines and we go over them together. He asks me about the risks associated with a tonsillectomy, and I'm honest with him. He asks me if I think Max should have the surgery, and I tell him that I do. He asks me if I think his son will be safe. Again, I tell him that I do. A few weeks later, Max had his appointment with the ear, nose, and throat specialist, accompanied by my sister and brother-in-law. My brother-in-law went armed with a list of questions that he and I had come up with, and this time, the physician sat down with him, looked him in the eye, and answered those questions one by one. In doing that, she gave my brother-in-law the confidence he needed to make the best decision for his son and for his family. Max had a successful tonsillectomy in February of this past year. He's a happy, healthy 6-year-old and will be starting 1st grade next month. His tonsils, however, will not. Thank you.
So it was the very first day of my psychiatry clerkship, and I immediately knew that this experience was going to be a little bit different. Our clerkship director started by offering us personal safety alarms, followed by, our patients are wonderful individuals, but you need to be aware and alert when you're on the unit. Honestly, her advice seemed a little bit dramatic for me. I had chosen to spend my clerkship on the child and adolescent unit because I wanted to learn how to support young minds as they made that tricky transition between child and adulthood. Raymond was the very first patient that I was responsible for admitting from the emergency room. His parents brought him in after he barricaded himself in the upstairs bathroom and texted the family group chat that he was going to swallow 10 bottles of Tylenol pills. I tried to do my diligent med school tasks and ask him about his thought process and events leading up to this, but he really wasn't interested in answering any of my questions. This attitude didn't really change his first couple days on the unit. He minimally participated in group therapy and didn't say very much during rounds, and spent most of his time looking outside the large window that overlooked the main boulevard in front of our hospital. I tried to think about his life experiences and moments that led up to this moment, but once again, he really wasn't interested in chatting with our team. Our fellow was not surprised by this behavior. He, like Raymond, was a first-generation person who had been raised by Chinese immigrant parents. He was initially interested in pursuing a career in childhood and adolescent psychiatry because he saw the need firsthand for there to be more culturally sensitive providers who work to destigmatize mental illness in Asian American families. One of my favorite parts about childhood and adolescent psychiatry is we were always instructed to think about our patient's presenting problem within the context of their environment. Scribbled on our workroom boardroom were a series of interconnected circles, labeled patient, family, school and peers, and finally, community. And us, if we were doing a good job, needed to search for a medical or social intervention that offered the most overlap between all of the circles. Eventually, we were able to get through to Raymond. We uncovered kind of a complicated dynamic of feelings of intense loneliness and sadness that first started when he was in middle school. He knew that his parents loved him. However, he didn't feel like he had the language to describe these complicated internal feelings, especially when recognizing the sacrifices that his parents took to raise him in America. Raymond's story is actually part of a larger demographic trend that shows that Asian Americans are less likely than other racial and ethnic groups to receive mental health treatment. Unfortunately, this disparity has only recently worsened, especially after the COVID-19 pandemic and accompanying wave of hate crimes directed towards this community. There is no one panacea for eliminating mental health disparities. Some people call for more education about common pharmacological agents such as SSRIs. Others advocate for more traditional healing methods being accepted as a part of Western medicine through things like integrative medicine. However, the literature consistently shows that in order to be successful, providers must first address the patient's cultural background, as that can often be the first step in establishing a strong therapeutic alliance. When we were looking towards discharging this patient, we really wanted him to consider the option of starting family therapy as a way to strengthen communication skills between him and his parents. During one of our last days on rounds, we asked him about this, and it was silent in the room. Just as it was becoming a little bit awkward, our fellow cut in with a really important question. Raymond, are you scared? He sunk his teeth in his bottom lip before slowly nodding in agreement. Our fellow responded by saying, I've been talking to your parents every single day on the phone, and they love you and they really want to get better, and they're okay with having these conversations. It can be really scary, right, to challenge centuries-old behavior and have that space for emotional vulnerability. But oftentimes, it's a really necessary and important step in the right direction. Thank you so much.
It was 11 p.m. on my internal medicine sub-internship when a new admission was paged out from the ED. 67-year-old male, history of alcohol use disorder, presenting after a fall. He had a pint shortly before the incident. My resident and I sigh. Watch him, give him the vitamins. Same deal as when he was here a few weeks ago. Probably just the classic old, alcohol-induced ambulatory dysfunction. I trudged to the exam room, prematurely irritated by the Sisyphean plan of a vitamin cocktail rolling down the mountain of substance use. He lay in bed, somnolent, his downcast eyelids like lampshades masking my scrutiny. His diffuse tremors worked through the Ativan's sedating effects. "Mr. Hudson," I yell, trying to get his attention, but his eyelids only drooped further shut. I solicited a history from his mumbles, ultimately deciding to just consult his chart. Because after all, would this encounter truly be any different from the last 5? When presenting all of his electrolyte derangements, cardiac arrhythmias, and nutritional deficiencies to my attending, I let Mr. Hudson's bottle count drench his personhood. The problem is alcohol, the solution is sobriety, and the infeasibility of the latter leaves me ill-motivated to probe any deeper. Later in his room, I watch my attending lower herself to his eye level. In that moment, I learn one of the most important lessons of my clinical training thus far. She sits back on her heels, takes his tremulous hand in hers, and looks earnestly into his eyes. She asks him who he likes to drink with and why. He replies that he drinks alone, that it's the 1-year anniversary of his son's death, and that the alcohol soothes his hurt. She asks him if he would be open to quitting, to which he says that yes he would, but no, he would not wait in the hospital for rehab placement. She gently presses further, and with several more minutes of teary-eyed conversation, he acquiesces, agreeing to stay inpatient as a bridge to rehab. I am internally slack-jawed, awed by how a clinician's authentic care can guide a patient towards a decision that will ultimately benefit their health. And so over the next few days, I practice getting down on one knee, speaking to the person and not the pathology. We talk about March Madness brackets. He agrees to starting Vivitrol injections, and I watch his eyes light up as he tells me about his daughter. The trust between us builds, and I start to write a happy ending. And then, over 80 hours since his last drink, and in the absence of any signs of complicated withdrawal, he seizes. Over several days, he emerges from the grip of withdrawal, still set on pursuing rehab, although now with steadfast intent to first return home. The timeline of rehab center referral, interview, and acceptance are all too uncertain, but we fear that each minute spent alone in his home would only increase his vulnerability to relapse. And so I kneel at his bedside, I call his daughter, I voice our concerns about the state of his health. But he refuses, adamant about returning home so that he can have his living will be notarized. And he's fixated on this affair, almost eerily so, as though he knows that his life now delicately hangs in the balance. But ultimately, who am I to deny this grown man the right to part from life on his preset terms, to refute his desire to pack clean clothes for the courageous journey ahead, to question his wish to visit his son's grave for fear of whatever sadness it might stir? In the success story of patient trust, I had naively always expected the patient to ultimately agree with provider recommendations. But trust is neither a thing to be won nor an active winning of patient compliance. Trust is to meet a patient halfway, to walk alongside them, and to encourage them forward while never abandoning them, should that journey grow circuitous. And so I stopped trying to persuade, again kneeling by his bed as I had done every day. "Don't worry about me. I'm a tough one," he says, smiling. And so I take his now steady hand in my own and look into his now open, mournful, yet hopeful eyes. Yes, you are. Thank you.
The thought of kneeling to meet people where they are Really incredible stories and experiences. Thank you for sharing them with me. We have now some opportunity just to hear from our students a little bit about what they've taken away from these experiences. So I just wanted to begin by asking you, maybe each of you, to talk a little bit about what you have thought about in terms of these experiences and your future careers, and what you may take forward in terms of how you plan to interact with patients in ways that you think can help to build trust. We see this opportunity to learn from you and to learn from your experiences. It's refreshing to have your thoughts on these issues as we think about institutions that we've created that maybe have appropriately created earned distrust. Would you like to start, Kaveri?
Yeah, I think that's a wonderful question. I think something that I noticed kind of in even the three of the essays that were shared is that change doesn't happen overnight and trust doesn't happen overnight. And I think kind of in our current day and age, we're so used to things just being instantaneous. We get our news in a second. Amazon packages come in 48 hours now. And I think that one of the things that I love is just the privilege of having time with patients and with their families, because I think when you have that time to actually have meaningful conversations, it just goes a long way in establishing a really strong partnership.
I love that you talked about that we have this opportunity to spend time in ways that are actually very meaningful both to us and to our patients. And time is one of those things that we always feel is so elusive, but yet I didn't hear enormous amounts of time that were necessary, but actually just making sure that the time you spent was really meaningful in hearing and understanding the life circumstances of the patients that you were dealing with. Meg, did you want to contribute?
Sure. I think for me, a major theme of listening to my other students and listening to the presentation this morning is that it's our responsibility not to dictate our knowledge, that we gatekeep our knowledge. We can't do that. We have to listen to the lived experiences of others and recognize that the lived experience of patient in room 1 is very different than the patient in room 2 is very different from myself. And we have to listen with the intent of acknowledging those lived experiences. And that's what I hope to take with me as I move into this, I should say, next phase of my career.
I think that that concept of really acknowledging the lived experiences of others is also a way in which we can become more trustworthy as physicians as well as institutions that are trying to deliver clinical care, and is something that really resonates with even the approach that we take in research that I think is so mirrored in these clinical experiences. Thanks for sharing that, Meg. And Ella, do you want to speak to us next?
Yes, thank you. I think from these essays and from my own experience, they've really made me kind of modify my original thought of how patients viewed physicians. I think I had always expected to kind of go in a room and nail a diagnosis and a workup and a plan and offer that to a patient. And I thought that's what they always wanted. But I realized through my experiences, on the wards, that what they want first and foremost is an ally. And someone who can kneel at the bedside or understand their past experiences, understand the broader context in which they're presenting, and then tailor a diagnosis treatment plan accordingly. But first and foremost, an ally. And so building that alliance is something that I'm really moving forward into my career trying to focus on first and foremost.
It resonates with me that we learned something this morning about where are the shared values or the shared understanding that we're trying to establish in order to really understand where someone may be coming from. And that sense of building allyship, I think, helps us with thinking about what is the shared goal here, and trying to understand that shared goal and really bringing that to the fore in order to build the trust that we want with our patients. I wanted to ask you a slightly different question. I mentioned many of us in this room really have the opportunity to learn from all of you and to learn from your experiences. I may say that some of us have been at this for a while, and sometimes that refreshing perspective of hearing from students and understanding the issues from a different vantage point really allows us to step back and think differently. We also shoulder a lot of responsibility that we've been part of an institution that really has earned mistrust and distrust, and recognizing a lot of the legitimate grounding that you described for earned mistrust in healthcare. And so I wanted to ask you how you're thinking about establishing your identities as new physicians coming into this profession that's really failed to garner what I think is the trust that we need in order to make sure we're delivering the most optimal healthcare for all. And it's a really difficult thing to think about in terms of entering a profession like that in that situation. But at the same time, we're looking to you to help us find some solutions. So maybe we'll start with you, Meg. And
Sure. So, sorry, just taking taking a second here. I think that as a medical student, and in my previous life, I was a nurse and nurse practitioner. I feel that being in healthcare is a major responsibility, but it's also a major opportunity to build trust. And so I'm excited to carry that on. I'm excited to continue learning, but I'm also excited to continue to have those interactions with patients and with families, whether it be in the hospital at the bedside, whether it be in the clinic, or whether it be out in the community, to really help to create positive interactions that will continue to build those trusts. And I think that we have to think about it as not an all or nothing thing. It's each interaction that we have is an opportunity to continue to build that trust. And we have to approach each interaction with the thought that we have that responsibility, yes, but we also have that opportunity.
Mm-hmm. That constant front of mind that this is not about overcoming a challenge. It's about really achieving what we think is the optimal approach. Kaveri, would you like to add?
Yeah, kind of similar to Meg, like prior to medical school, I worked as a clinical research coordinator, and we did a lot of work with the community in the Washington, D.C. area. And I think something that I really took away from that experience is that healthcare systems, even if they can feel very separate, I don't think that's a good thing. I think they should be integrated with their local environment, kind of understand what the goals are of the people who live around them, because that's just ultimately going to impact the relationship that patients will have with providers. And it's not easy. Sometimes being in such an academic sense, that town-gown relationship can feel very separate. But something that I'm really looking forward to and hopefully in my further career is just trying to kind of decrease, I guess, that social or emotional difference between what it feels like to go to the doctor's office versus what it feels like to just have confidence and faith in providers in your area, that they really understand what your goals and also what the community's needs are.
Mm-hmm. I think that's also another aspect that we can carry over from this morning's discussion, really about that opportunity to think about the integration and opportunity to embed healthcare systems within a community in a way that we're thinking about the social construct of the community as a responsibility of how we actually work in that setting. And so I appreciate you for pulling that forward. And what Kaveri didn't add is that some of that work was done with a former colleague of mine at the National Institutes of Health. And so I understand deeply what you're referring to and that amazing work that she's undertaken. Ella, can I turn to you for a moment?
Yeah, I think echoing a lot of those sentiments, there's just so much value in understanding and knowing the legacy of mistrust in healthcare. I think as uncomfortable as it can be to sometimes confront that, I think knowing it and knowing, and also being very in touch with the community, knowing kind of what their needs are, what the apprehensions around healthcare might be, kind of leaning into those is the first step in trying to improve them and dismantle that whatever legacy of mistrust might lie. And so that's definitely something thinking forward that I want to carry into future identity as a clinician is kind of being cognizant of the wrongs of the past, and instead of trying to immediately erase them, leaning into what's been done and figuring out from that how can we better the system.
Several of the experiences that you talked about, and I think, Ella, you just hit on it as well, reveal this potential that an individual interaction actually can have greater ramifications, either for parents, caregivers, family members, or even the greater community. And so I wanted to drill on that a little bit and ask a little bit about your perspectives on how we leverage that power of that individual interaction that you talked about to think about the broader implications or even build the trust of the many, the family and the community as well. Ella, maybe I'll start with you online if that's okay, since it's a further on your comment.
Yeah, I think as far as using those individual interactions, I mean, so much of healthcare is, yes, it's doctor patient, but it is also, ultimately like doctor family, and as you're saying, within that doctor community. And I think inviting other individuals into the conversation, like it's very common to round with families or invite them in for family meetings. I think trying to bring other people into the conversation as well allows it to be a broader discussion, and that allows any positive interaction that's built and positive trust that's built with a patient to kind of reverberate outwards into the lives of other people, and will shape how they view healthcare as well.
Mm-hmm. I think, Kaveri, your story about the family and really the sense of a cultural way in which the family didn't talk about mental health or think about mental health interventions, and the fear that your patient had about the family reaction speaks a little bit to this concept. And I wondered if you had any further takeaways on that perspective.
Yeah, I think it's sometimes to kind of make interactions make sense to me or go easier, I always think about what it's like to be a patient, especially in an inpatient environment, how stressful it can be, and how many people are talking to you and giving you maybe like what seems like a lot of complicated information. And I think that oftentimes when people are in that environment, they really look towards whether it be their biological family or family of choice to kind of help them through those stressful periods. So they can, family members and whoever might be there to support the patient can be such allies. But obviously in some situations when there's maybe some emotional distance there, it can also be really challenging to get kind of these two groups of people to work on the same team, so to speak. So I think the themes that we've been talking about this meeting, just a lot of active listening and understanding possibly like what each side's goals are, and figuring out a way to just kind of speak similar language between the two groups has been the best method that I found to move forward. And oftentimes, like, they really do have the same goal. They're just maybe using slightly different language or to have slightly different paths to get there. But ultimately, like, for most of the experiences that I've had, the love and the care and the desire to want for better for that patient is always there.
Thanks. Meg, do you want to add anything?
Sure. I think that if we learned anything this morning, we learned that people talk, and that social media makes these communities, can make them stronger and closer. It can also make them grow further apart. And there's a lot of space where we see negatives out on social media, and we see that the community can be infiltrated by those negative, pervasive attitudes. However, I think it's important to consider also that media can be an outlet for positive as well, and that each interaction, I keep going back to the individual interactions, each individual interaction that we have with someone could potentially have that ripple effect of positivity as well.
Well, these were amazing stories. I want you to put us in the situation where we're now your students and you're our teachers. And if there was one thing that you wanted to make sure we walk away in terms of understanding what you would want us to embody and embrace in order to continue our journey and legacy of rebuilding trust, of thinking about how to be trustworthy, what might that be? Would you like to start, Kaveri?
Sure. I think it's kind of speaks to one of the themes of the first speaker. It was wonderful. I learned so much from that, but especially as a student and the long path that it takes to become a provider, there's a lot of years there, and we really look towards, especially our attending physicians, as being kind of these examples. And I think it can be really powerful when you don't know to just admit that and say, like, I'm not sure, but I'm still, like, I can get back to you, or let me like look further into that, because I think sometimes as students, like, there's so much that we don't know, and it can feel very intimidating to admit that. So seeing that reflected, I know it can be difficult, but it's also very powerful.
I think that may be the intellectual humility right there. So great example of that. Meg, did you want to add something?
I would say engage in dialogue and listen for the sake of listening, not for the sake of gaining information that you can then dictate to your patients. We have to have these conversations, and we have to really talk and listen to our patients.
Great. And Ella?
I would say ultimately, patients are people, and it seems like a very, cliche thing to say. But I think a lot of times We know that internally, but sometimes our actions don't always reflect that. And so figuring out how to really honor that person who's sitting across from you as though they're your friend or your family member, figuring out how to, within one's daily practice, integrate some habit that really honors and acknowledges that person who's there is something I would recommend her.
Fantastic. Well, we want to make sure that the audience has a chance to ask you questions that may be on their mind, reactions they may have, or comments they want to share given what they've heard from you. So I'll invite anyone that would like to come forward with a question or comment to do so at this time. I see one in the back here and then over on the left as well.
Yeah, just like Ella, your image of going onto a bended knee to come closer to the patient is a really, really compelling take home. Would you be willing to say another word or two about what it meant to you and what you take away from that metaphor?
Yeah, absolutely. Thank you. It was a very powerful thing to see my attending do, and I think it was honestly in the moment. It was one of those things that it happens, and you're like, why did I never do that? Like, why was I always standing in the doorway or leaning over the bed? And I think it really made me think much more critically about body language when you're walking into a room, and something that I try to do now every time I walk into another patient's room, figuring out how to. If it's not getting on my knees, like lowering myself closer to their eyes or leaning over, not over their bed, or figuring out how to position the chairs during a family meeting, trying to just not have this like top-down interaction that I think can so often be the case, or you run the risk of having be the case. So it was a very, very impactful thing to see, and I think that just that image, or that the act of being at someone's eye level is a really like powerful act of almost like equalization, saying like I'm like we are both people, and I think was very, very humbling.
I love the way you talk about that in a sense of breaking down power dynamics, which I think really, if we're talking about trust and trustworthiness, it's about trying to figure out how we share that power, both from a physician-patient interaction as well as from physician, community, and other family interactions. Thanks for that, Ella. I saw a question on the side there.
Susan Denser, CEO of America's Physician Groups. Thank you all. You do give us a lot of hope. Picking up a bit on that prior question, if I recall correctly, both Kaveri and Ella talked about how that technique of bending down to the patient's eye level was modeled for you by your attendings, which I thought was really interesting and striking. And because it wasn't that many years ago that we were talking about things like the culture of bullying in training, with attendings bullying their trainees, including medical students. So, and I realize you may not have the perspective of years to answer this question fairly, but it does seem like something has changed in the culture. If there are attendings modeling this behavior for you, that may be different from what was the case 10 and 20 years ago. So I'm wondering, do you feel that the culture now throughout medical education is rewarding this new or different paradigm that may have been true for prior generations of clinicians?
Would anyone like to start with a response there? Kaveri, would you like to start?
Yeah, I'm like, yes, I'm only a fourth year medical student, so I've had about like 1.5 years of clinical time. But from what I can tell, like maybe some of the culture related to bullying is because people were simply so overworked. And I feel like it's hard to be your best self when you're exhausted and you're hungry and you have no time for your personal life and things like that. And so it was a very, maybe punching down kind of environment. That being said, I feel like there is, at least in my experience in my institution, more so like a focus on just like wellness, but also like I think greater support for, there being emphasis that it is a teaching environment and they're going to be learners. And the people that I've worked with have been very, very accommodating of that, and also like wanting you to be involved, even if it means, that the team might go a little bit slower or things might take more time just because there are more learners. I do think that the kind of combination of improving a little bit more like physician wellness and even having those tough conversations about like physician suicide, resident mental health, things like that have led to just a better culture in general that is just more inclusive of medical students as learners. So I don't know if they're being rewarded in maybe like the traditional like accolade sense, but in terms of like my learning and like my comfort being in that clinical environment, it's probably better now than it was years before.
Thank you. Ella or Meg, anything you want to add?
As a non-traditional student, I've been in healthcare for several years. I'm the designated mom of my med student class. And so I have seen that shift over the past 15 years that I've worked in healthcare. I think that what I have witnessed specifically in facilities that I've worked in is that there's an improvement in interprofessional collaboration, and we're relying more on each other as a team. And I think that is helpful in terms of those what used to be perceived as power dynamics. Now they're looked at more as team collaboration. And I think that has gone a long way to improve the civility among everyone that's working in the system.
Well, I want to personally thank you all for inspiring me, giving us hope, as you heard here, and knowing that the future of medicine's in really good hands. And if we can take an example and lead from you, then we're going a long way to where we need to be. So thank you again. Thanks for your questions, for your interest, and let's give them a round of applause.